The reason that I'm having the American Cancer Society logo on this is that I've done this type of education for a long time. I went across the state as a logic model facilitator for the Department of Health for years as a helper. And then when I came to ACS in the year 2000, the national planner group that I was part of, we tried to figure out how to make synthetic estimation available to the common user. And all it really is math literacy. So I'm here to either remind you that you have math literacy or that you didn't realize you had math literacy. And I'm going to focus in on a certain skill today. That's a very important skill in program planning and evaluation, both, because it has everything to do with setting goals for activities. We're going to look specifically at the behavioral risk factor survey to use as one way to set your own activity goals for your programs, and then use those goals to calculate numbers using demographic data about how many need to change for us to see a bump in a percentage or a trend line. And then you'll be able to describe two ways at least to track results of your activities. What that is, if you're a logic model user, is just setting outputs, which is how many do we need to quote-unquote target, and then in planning, how does that connect to our resources and our activities planning, and then at the end of a defined period, how are we doing at getting our goals accomplished, meaning that you're counting numbers and you're comparing the how many to that we wanted to see versus how many did we get, okay? So the adult behavioral data for Pennsylvania and the United States is available easily at multiple websites. I always use the Pennsylvania Department of Health website. The behavior data is collected annually by the CDC in a household survey. It's adjusted with really sophisticated methods, and it gives you information on basically prevention, screening, and many other questions that are asked each year or every other year, such as insurance status. So the behavioral data set is one that you should be using in your work, or someone in your team should be using. And you can get it by county sometimes. You definitely can get information by the regions of the Pennsylvania Department of Health. And there's an example of a map of the regions. And you also can certainly get it for the state and the nation. So it's an important, informative website about how well are we doing and where are the gaps and problems related to certain kinds of population groups and healthy behaviors. I always tell people, if they're looking at the regional differences across the state, in case you're a statewide program, to use data averages that are 3 or 5 year. Alan could look at 3 or 5 year data averages in those smaller counties. You may not be able to get it for a single year, but you might be able to get it aggregated. So that's a good idea. And in the behavioral data, I just said you can get counties or health districts. And you want to locate counties or districts that are higher or lower, again, that idea, than the Pennsylvania average, because that might give you information towards someone who's increasing a healthy behavior, so it's higher than the state, or who is behind in a healthy behavior because it's lower than the state average. And that way it can help you maybe set priority counties for different programs and aim at high-risk groups, because these behavior data are broken down into really great demographic categories that tell you more about the who, so you can calculate the how many do we need to get. Here's an example of just basic synthetic estimation. If you want to increase to 70%, and I use breast cancer because that's an easy one to use, the recent screening rates of women 40 plus, okay, so that would be 40 on up into infinity by 2020. If you look at the behavioral risk data, the latest report, which is 2012, 60% of women in that category had a mammogram in the past year. And if you want it to be 70%, that's a 10% difference between where we are now and where we want to be, okay? How many women would equal that 10%? Well, you would want to look at the demographics and multiply your population group by that 10% to understand how many women would that mean. And you're going to see this over and over again to make that idea come home. You have to ask yourself, who needs to change the most? So anytime you look at a table, and let's say I said the goal for 2020 is, in this case, 70% for those 40 to 49 years old, and the goal is higher for those in the 50 to 74 age range. Okay, and these goals are set by various groups, and I'll get into that. And then for older women, 75 years plus, the goals are a little different, but the 2012 behavior risk data tells us what can we say with some confidence about where we are in the reports of getting mammograms, self-reports from the people themselves. The difference is over on the right-hand side. Where is the largest difference? The 18%, right? But the least difference between the goal and where we are now is the 65 to 74-year-old. And you can hypothesize that that's because they're coming into Medicare, they have their mammogram covered, whether it's their first mammogram or whether it's a repeat mammogram from the past for screening. So that there kind of hints to you that many women coming into Medicare are going to get these types of healthy screenings, but those who aren't coming into Medicare may be falling behind. That's what that kind of table tells you. But if you look at some of the socioeconomic breakdowns that we have from the Behavioral Risk Factor Survey, which are excellent, you can see here that if you set the goal at 70% across the board for groups, and you look at the reports of where are they now versus where do we want to be. All right, the first column is where do we want to be, and 2012 is where are we now. There are the differences, and you can see here that the largest is among the low income. No surprise, although we're hoping to really see that change with the Affordable Care Act. We're hoping, okay? But this begins to give you ideas about your target audiences for your health promotion activities. Now, if you're using a different goal than annual mammogram 40 years and older, let's use the goal that's put out by the United States Preventive Services Task Force, which you also can find on the government websites and the CDC. If your goal is we want to see a mammogram every 2 years among women aged 50 to 74, that helps you think differently about your goal and the numbers, all right? If we inspect the 2012 BRFSS, we can see that for that age group, 80% in that age group met that mammogram goal, all right? And we've got a goal of 81% set by the state of Pennsylvania for this, so that's just a difference of 1%. But don't get fooled by 1%, because that can mean still a lot of women when you apply the population numbers to 1%. So the message here is you have to choose which goal you're going to march to when you set your results of activities goal. How many women do we want to reach? Versus, are we ready to do that on the specific population groups that we want to target? And then in planning, in evaluation, how many women did we reach? You have to decide if you're going with the 2-year goal, for example, in breast cancer, or the 1-year goal. And they're also different age groups. So that's one caveat in this kind of estimating for setting your goals. Now, when I looked at a table, and I just typed it up myself here, what does this table tell us from 2010 to 2012, from right to left this time? Every 2 years, a mammogram among women aged 50 to 74, who looks like they're the most in need. And again, you need multiple pieces of data to make decisions. But as I teach my students, just whenever you look at a table, you always look for, is everything moving in the same direction, or is something moving backwards? So here we go from 79 to 80. All right, that's the goal itself towards 81. So we're moving in the right direction for that United States Preventive Services Task Force goal. Non-Hispanic whites is also moving, although it's kind of the same, because that plus or minus 2 means there is no real difference there. They're actually the same. But the direction in raw numbers is moving. Non-Hispanic blacks, huge jump. I actually had to go and check that 90% a couple different places to say, oh my goodness, and I cannot explain that. And let's see if it holds up next time. That would be my concern, because 79 to 90 is a huge jump, and that is statistically different. These are percentages of women reporting that indeed women aged 50 to 74 got a mammogram, okay? Hispanic data is not there yet. We'll just say yet. But they haven't broken that out yet for this goal. Now, people who lived in urban areas are moving in that same direction. 2010 to 2012 shows a bump. It's pretty equal, though. Rural also is pretty equal, but a direction looks like it's going backwards. That would only concern me if that continued and then it became statistically significant, meaning that if you add or minus 82, 82 minus 3 gives you 79. That means there is no difference. These are still equal. But once those numbers don't cross each other when you add or subtract, then it becomes significant. But the fact that rural bumped down, I'd want to see that trend over time before I got worried about it. And I want to see it be significant, not so equal. Less than high schools moving in the right direction, high schools moving in the right direction, and some colleges moving in the right direction for that type of goal. Also looking at, for the United States overall, women 40 plus, annual mammogram, okay? This gives you a lot of information around age, race, education that's important. And looking at the past year, 40 plus the past year, you'd want to find the worst percentage report of getting a mammogram, and that would probably be 38, right? Those with low education, which high school is a real marker of opportunity for success in our culture. So those who didn't graduate from high school are reporting mammograms in the last year the least, and in the last 2 years, still 40 plus age, not that 50 to 74. Who looks the worst on that column? Again, it's them. So it's telling you right there that you're lower income and lower educated, which you know from looking at tables, but this verifies it and gives you a way to communicate to your staff and to your supporters why you're choosing to do what you're choosing. But I also was really taken with this, which wasn't something we had years ago, and it was the immigration data around mammography behavior, and it's available for other kinds of behaviors. And what stood out to me was if these women were in the United States less than 10 years, that by far takes the cake in all of these tables. It's just a standout. And I work as a community health nurse once a week, sometimes twice a week, in the center city of York, in public housing and subsidized housing. And we have women who are recent immigrants who are still haven't obtained, believe it or not, their United States citizenship. And I can see that in my own clinical practice, that oftentimes they are so behind in all of their healthy behavior screenings. And here it bears up. The other group that I think is extremely at risk are those with mental illness. And where I work, more than 50% of the people have mental illness. They have a ton of chronic conditions. They have diabetes. They're younger than 65. Many of them are on Medicare, though, because of disabilities. So women with disabilities, there's been more data out on the internet about that. you don't see as much about women with mental illness, but they'd be inside that women with disabilities. But there are plenty of women with mental illness who are not inside those numbers. And then this notion of those who are coming into our country within the last 10 years. That's where the lowest percentages are. And these are the way that you can think of looking at data to help you target audiences. But synthetic estimation itself, then, you have to choose which goal you're going to plot yourself against. You can choose all of them and look at them all and then make decisions, right? If your group says, oh, we want to go with some of the major nonprofits who have a more liberal goal than the government, you know, it's up to you. Then you select your data sets. Compare where are we now to where do we want to be. And you can use the goals that are set for you by the government, by the Department of Health here in Pennsylvania. Anytime you go into Healthy People 2020, you can see what are the goals. Are we meeting the goals? But you can't fool yourself that you stay with totals. You have to dig into the demographic breakdown and say, who's at the worst? Or near worst, or where can we make a bump in this with people that are on the lower end of reporting healthy behaviors, okay? And you have to then identify your priority groups in need. Then the trick is to estimate how many. That's what gets me to today's topic. How many does that mean? And how many should we try to get? And it also tells you, you better collect the data to know you're getting them, right? If you have you been in the country less than 10 years, if you're actually trying to target that group, how long have you been in the country? I mean, you may get different answers, but you can kind of get a gist of, are you getting those folks? If you didn't ask that question and you set a goal to get the foreign-born, you can't decide in your evaluation if you got them if you didn't ask that question ahead of time, okay? You're going to remind yourself that you have math literacy. Let's say fill this in for county municipality. We're Dauphin and we're Harrisburg, okay? And we're going to look at that annual mammogram, 40 plus. But then you decide, well, we want to do annual mammogram, but we kind of want to make it 50 to 74 age group to kind of do a hybrid of the two goals. So we're going to do 50 to 74 age group, annual mammogram, okay? Population size in Dauphin, Harrisburg, and I rounded up for your convenience. You want to fill in 6,000 for the population size. All right? And the ages, 50 to 74. Other, I put female. Where are we now? The BRFSS tells us that for that age group in number 2, we are at 60% reporting they have a mammogram in Dauphin and Harrisburg. I told you before, larger counties. So where are we now? You mark that again, 6,000, multiply by 60%, and what does that give you? The actual number of women in Dauphin County, in Harrisburg City, who are reporting they have a mammogram, who are between the ages of 50 and 74. Follow me? We'll do this a couple times so you get it. So what does that equal? 3,600, right? Then where do we want to be? Well, we have the same number of women, 6,000. We want to be from 60 to 70% reporting a mammogram. So we multiply by that, and we want to be at 4,200 reporting a mammogram, all right, by, let's say, 3 years from now, okay? So 4,200 from 6,000 is, the difference is what? 42, I'm sorry, I said that wrong. 4,200 is where we want to be. 3,600 is where we are. See it? Yeah. 600 and some of you know how to do this, 600, and let's say we give ourselves 3 years to get there, so the number of years to get there is 3, we have to reach 200 new women, not those who are already getting it. They have to repeat it annually according to this goal within that age group. We have to reach 200 new women per year, ideally, in order to get to 70% in 3 years. Get it? We're going to do it one more time with something different and then compare the differences. We're going to do Dauphin County, but with the 2-year mammogram. We want women to report a mammogram every 2 years, all right? The same age group, 50 to 74, Dauphin County, Harrisburg. Same population size of women in number 1. And number 2 is same population size. But right now, where are we now? Remember that 80%? We were really close to the goal. So 80% of 6,000 is 4,800?
48.
Yeah. And where do we want to be? It was just a bump of 1%, remember? And how many women does that mean? That's 4860. And so the difference of 4860, where we want to be, the goal, minus where we are now, is quote-unquote just 60. And we want to give ourselves 3 years to get there, which is 20 new women a year. But remember, that's just in the city of Harrisburg, and it also means everything you are doing continues. So don't think that's small, but you can congratulate yourselves if each year you get 20, because you know if nothing falls apart, assuming nothing falls apart, you will reach that goal in 3 years of the 1%. That's if everybody keeps getting mammograms. So you have to decide, are we focusing on those who don't get mammograms? Are we focusing on keeping those who are getting mammograms? Are we doing both? And that would mean you'd have to start asking women, is this in your program, is this the first time you've had a mammogram? Or somebody has to ask it for you to even know that they're going to get a check mark for the 20. Okay? So there's a big difference between what goal you're going to march to, isn't there? Between 20 versus 200 a year. 20 per year for the 2 years, 50 to 60, 74 year age group versus annual, 200 a year. And you have to make that kind of commitment, or you just track both of them and sort of see where you end up. Let's do one more because it just knocked my socks off. That foreign born. Let's do foreign born in Dauphin County, Harrisburg, okay? I calculated with my own calculations that they have foreign born less than 10,000, less than 10 years here, women. They have 3,800. And I can tell you how I got that offline. So your population size is 3,800 in Dauphin alone. And if you know you've got a lot of immigration coming into your county, this is going to matter to you. So right now, they reported 27% of them are getting mammograms. All right? That means 1,000 of them are getting mammograms now. And where do we want to be? Well, I set it at 30% in 3 years. All right? Somebody's going to set that goal. So 30% of 3,800, are you following me? And if you're not, I'll see you on a break, because there's always one student that's daydreaming. There's the ideal number, where we want to be. So where we want to be minus where we are now is 114 new mammograms among those foreign-born less than 10 years women inside that age group, okay? 3 years to get there means that we need 38% 8 of them per year reporting mammography as new. That's a sizable number. That's bigger than you think. First of all, you've got to find them and get them there, or figure out what systems they're in. And many of these may be uninsured or just getting onto insurance, and maybe getting mammograms is the last thing on their list because they just came to this country, okay? So if you want to target 38 per year, it will change your activities, your strategies, and your inputs. That's what synthetic estimation helps you do, is change percentages into real numbers and helps you reconfirm who is it that you want to help, okay? Here is the basic way that we just did this. If you had a county, this is just an example, if you had a county female 40-plus population of 10,000, inside of that number are the low income and the low educated. If you're at 60% for the state of Pennsylvania, which is what we're at now, there were times when we were higher, getting mammograms. That would mean 6,000 women out of 10,000 are getting mammograms. We want to get to 70%, the 2020 goal, which is set. By the way, it's been stuck at 70% for a few decades. That's a difference of 1,000 women. If we take 6 years to get to 2020, which is about right within a planning cycle, because you have to plan and set your money next year, etc. That's 170 females who are getting a mammogram, an annual mammogram per year for the state of Pennsylvania. 170 new women, unique women, okay? We did the exercise. This is just a basic step in any problem-solving method. Weight Watchers uses it. The United Way uses it. You have to set goals as numbers and then see if you're getting there. And then if you're not getting there, it gives you information on how to either reset your goal or plan again or reset your resources. For county-level demographic data, now these hospitals all have to do these big community assessments every 3 years. And they're going together maybe with multiple counties. There's fabulous online public data there for you to use if you don't want to dive into the census. But the census is so easy to use now in terms of, very similar to EpiQMS, in terms of drop down and selection. I go to American Fact Finder all the time to get my numbers. Are these types of target groups living in any concentrated pockets within your geographic reach, right? And then you ask yourselves, how do we get to them? How do we encourage them? Who to work with? The opening doors, with their groups. Who serves them? Who knows them? Who works with them? Who could work with them? And where are they and who are they? And do they have gaps in services? The classic one, transportation, which we never seem to solve. You also can do it for youth. In Philadelphia, they have the Youth Risk Behavior Survey. You can do it for tobacco with the Youth Tobacco Survey. So you're not just confined to this kind of estimation with adults 18 plus. And it helps you assess the problem, summarize the problem, figure out where you can do your work, and prioritize your goals, and then use those goals as your evaluation, okay? I see this as not just a typical planning evaluation method, but a communication method. People respond to numbers and percentages. You're not throwing them off with age-adjusted rates and this and that. You're talking about behavior change, which people, the common audience, can grasp. So I think synthetic estimation in this simple math way is a fabulous communication tool to get other partners on board, to show people that you know what you're talking about, you know how many, and also for you to track if what was behind you, where we are now, is holding up as you go forward and try to make things even better, okay?